Good afternoon, everyone. You are all very welcome to our Sláintecare webinar. I'm Gráinne Healy, Chair of Citizen and Staff Engagement here with Sláintecare, and I'm delighted that you've joined us for today's webinar, the 10th Sláintecare Integration Fund webinar, part of our Learning Network event series. First up this afternoon, I am delighted to welcome the Executive Director of Sláintecare, Laura McGahey. Just 2 weeks ago, the new Sláintecare Implementation Strategy and Action Plan 2021 to 2023 was launched. And we thought it would be great if Laura gave our viewers just a short overview of the new strategy. So here she is to present the new strategy to you.
Sláintecare is about reforming Ireland's health and social care system so that it can meet the needs of our growing population, attract and retain the very best staff, and ensure that a safe, timely service is available to everybody at low or no cost. Since the establishment of the Implementation Office in late 2018, steady progress has been made in implementing key Sláintecare reforms, and we now have an ambitious programme to deliver over the next 3 years. We have all been through a great deal in the past year, and the pandemic has been extremely challenging for everyone, particularly in the health and social care system. It has emphasised the strengths and gaps that exist, but also the scope and desire for reform. We've seen some wonderful examples of innovation and change, and yet we have clearly witnessed the impacts which the wider determinants of health have had on our population. This has led to the decision to focus on 2 reform programmes with 11 projects for the next 3 years. The first is improving safe, timely access to care and promoting health and well-being. And the second is addressing health inequalities, moving towards universal health care. Successful implementation of the 2 reform programmes will have a really positive impact on our health system and will benefit everybody across the country. The programmes will result in people getting timely care as close to their own homes as is safely possible, and will also focus on prevention initiatives to promote health and well-being. Healthy Ireland is the prevention pillar of Sláintecare, and the Healthy Ireland Strategic Action Plan 21 to 25, published today, will guide delivery of the Healthy Ireland framework over the next 5 years and build on the progress already made. The Sláintecare programmes will also support those requiring more targeted health and social care interventions through a population planning approach, and will progress the vision of universal healthcare. With the goodwill, funding and implementation focus that has been built up for Sláintecare, collectively we have the opportunity over the next 3 years to implement these programmes at pace and continue to translate the all-party Sláintecare Oireachtas report from a shared vision into reality. Thank you to everyone involved in Sláintecare implementation.
So many thanks to Laura, and it is great to hear about the new Sláintecare strategy and the Healthy Ireland strategy, building on the work since 2018, work so many of you are directly engaged in. We are taking questions this afternoon during the broadcast, so if asking a question or making a comment, please do indicate who the question's for, and we will make sure to get the answers for you. The Q&A button is at the bottom of your screen, and if you type in a question, it comes straight here to me. We are very happy to be delivering these webinars in conjunction with the Health Service Executive and with the support of IFIC, the International Forum for Integrated Care. Sláintecare is about providing the right care in the right place at the right time by the right team. And in these webinars, you'll hear how the projects funded by the Sláintecare Integration Funds and some HSE funded work is showing us best practice for healthcare reform and displaying how many have adopted work practices and created improved pathways while responding to COVID-19. This afternoon, our focus is on collaborative working for innovation and change. We are featuring presentations from 4 Sláintecare funded initiatives, which are providing care in ways that's bringing together people from across the healthcare and community sectors. Some are specialists devising new and improved care pathways for those suffering from chronic pain. Others are devising innovative approaches to prevention of illness, ensuring that we're all staying mobile, healthy, and staying well at home where possible, thus shortening waiting lists, reducing footfall in acute hospitals or indeed to GP practices, and thereby improving the experience of people who use the health and social care services, while also improving health and well-being outcomes. All of today's initiatives are about demonstrating collaborative working. One is about sharing an innovative approach to stroke support. A second is about community-based physical activity interventions for people with mental health difficulties. And the third is about rehabilitation for arthritic knee sufferers. There's also an initiative from the Cork Sports Partnership to show us how citizens can be empowered to manage our own health through physical activity and healthy eating. Again, limiting the need for hospital admissions and supporting people to stay well in our own communities. All of these approaches have clear positive outcomes for patients and for services, and they're all helping to deliver models of care as envisaged in the HSE corporate plan and the recently published Sláintecare implementation strategy and action plan, of which Laura just spoke, aiming to build a responsive and multi-pathway route to care for patients, bringing care closer to home for many by locating it in the community, and thus better meeting patients' needs closer to home by the right team in a timely, efficient and effective manner. So let's go to the 4 projects doing innovative and effective change work through collaboration and partnership, leading to alternative and improved pathways for patients and service users, and also leading to improved outcomes. As Sláintecare continues on a journey to ensure the right care, right time, right place, these projects allow us to demonstrate to you what Sláintecare collaboration can lead to and what it looks like on the ground. Our first project for you this afternoon is from County Wexford, a best practice recovery focused care initiative, a collaboration between Wexford Mental Health Service, Sports Active Wexford, Wexford County Council sponsored community programme, and research supported by the Waterford Institute of Technology. Let's hear from the Exercise Effect project now. I am very pleased to be joined this afternoon by a really interesting initiative down in the southeast called the Exercise Effect. I'm joined by Paul Lowney, who's the Service Reform Project Lead in Mental Health Services with Southeast Healthcare, and also Anna Flynn, the Integrated Exercise Practitioner for Mental Health. You are both very welcome. Thank you so much for giving us your time this afternoon. Paula, can I come to you first of all? Our webinar this afternoon is all about collaborative working for innovation and change. And maybe you talk a little bit about who are the partners that you're collaborating with and what is the change you're implementing? What are you doing there?
Thanks, Grania. So the Exercise Effect project is a partnership between the HSE Mental Health Services in Wexford, the Sports Active Wexford, which are embedded in the Wexford County Council. They're the local sports partnership. And also we have our evaluation partners, which are WIT in Waterford Institute of Technology. So basically we came together when we had the opportunity to make the application to the Sláintecare Integration Fund. All 3 partners had been doing some work in their own way in relation to mental health and physical activity, but we saw this as an opportunity to really get some tailored individualized programs right into the frontline mental health services through the model of integrating an exercise practitioner into the MDTs. And we saw working in partnership as the way to do it, because obviously you get the sports expertise and the health expertise, physical activity from the sports partnership. you have the mental health expertise from the mental health side teams, but when you put it together and you can integrate the practitioner onto the team, that's when you really get the best results, because everyone is supported then in the delivery of care to an individual who's
great
in recovery.
example of collaboration. And Paula, you know, right care, right place, right time, right team. This is a kind of a neat way of describing what Sláintecare does. So tell us how your project fits with this model of care.
So I suppose with right care, right time, right place, what it does is, I suppose this project enabled us to create access to integrated exercise practitioner services. So the clinicians on the teams and also the service users themselves can refer for physical activity as an intervention to support their mental health recovery. And I think that's really meaningful, because there is a lot of literature and evidence out there that states the benefits of physical activity for our mental health in general, but particularly for mental health recovery. So mental health services deal with people who are actively experiencing, mental health difficulty at the threshold level where it's, it may be a significant problem for them. So giving them access to tailored, individualized physical activity as a tool that they can use for their recovery alongside other treatment modalities is really, really valuable. And particularly in a way, because physical activity can be used as a self-management tool beyond the lifetime of the access to the exercise practitioner's intervention. So they're getting the access to the treatment, I suppose, at a time when, they're in active recovery themselves, but we hope that the actual effects will be more long-standing than that. So building the pathway and working in partnership to get the practitioner employed, but then we had to do a lot of work on the service end to develop, I suppose, the operating procedures that would allow a referral pathway, the confidentiality structures, all those kind of things that really made integrated care actually work in practice. That all groundwork had to be done with this project as well.
Great. Perhaps if I go over to your colleague now, to Anna. Anna, talk to me a little bit about, we said it's about mental health, but how do you actually access the participants? How do you get them on board? And what do you do with them when you get them on board? You as the practitioner, what are you doing, Anna?
So I get the referral in from somebody on the multidisciplinary team. So then I revise over the referral form, and then I meet the client for the assessment. I suppose the beauty of it is that I meet the client where they're at. So we plan through the 8 weeks, and depending on their goals, then their plan is completely tailored to them. So for example, there was one child in CAMS who would have OCD and an eating disorder, where this child was going completely overboard with physical activity, which is on the other side of things. So in that case, it was about educating and training the child or the teenager into safe and healthy exercise. So as you can see, it's a range. There's such a wide variety for everybody that I couldn't even.
And Anna, is it all one-to-one custom-built programs for each person? That's fantastic.
Yeah, so,
right.
Yeah, so that's exactly it. It's one-to-one intervention. Now I know we're going to be talking about the COVID-19 adaptations, but working one-to-one and then integrating into the community is the goal there.
Yeah. And when you say you get referrals in from a multidisciplinary team, so that could be a GP, a psychologist, it could come from any of those agencies. Okay, yeah. And they contact you. Do you also work with older people, or is it just young people that you work with?
No, so we work right throughout the lifespan. So CAMS, the children, adolescents, the general mental health services, the rehabilitation, recovery, and then we also work in psychiatry. But I also work in psychiatry for later life as well. So right through.
Very good. So maybe we'll just go back to your colleague Paula. In terms of all the various partners that you're working with, what are the challenges that the project has faced in developing the partnerships that are supporting the programme?
I suppose one of the initial challenges was how to sort of operationalize something like the exercise practitioner within the Irish context. So there's exercise practitioners working in Australia in mental health, in the UK, in the NHS services, but the pathways weren't exactly as clear within the HSE how we would make it work. So having the opportunity to work in collaboration with the local sports partnership with Sports Active Wexford, and Fran Ronan there is the coordinator, who were willing to, I suppose, do the employment part for us. You know what I mean? So they did the recruitment of the exercise practitioner on a specifically developed job spec for this role, because obviously it's not just anyone's role. You know, it does take a special skill set, and Anna, in fairness, has that skill set. You know, that has a lot of health knowledge, but also has an interest in facilitating people's recovery from mental health, but being an expert in using exercise and as Anna said, just meeting the person where they're at with a wide variety of interventions. But one of the core things as well, so once we were able to do that, then we had to work out, well, how do we navigate the integration of the exercise practitioner who's externally employed into our mental health services? So that's where a lot of negotiation would have happened with management and developing the standard operating procedures and the confidentiality around that. But one of the really great values, I suppose, of having a local sports partnership employee integrated into the services is that they look beyond our services. So Anna's not, you know, doesn't have a gym in the local day hospital, you know, when it's bringing people in or out. She is out in the community. So her sessions happen in back gardens. They happen in the local parks, in those facilities that are being created by Wexford County Council for the benefit of population health. But Anna is bridging that gap for individuals who need an additional support due to their mental health challenge to get out there and get doing it. That great feeling of success. And I know some of the testimonials that we've seen coming from Anna's work is about that feeling of success and getting out there into the community. And I suppose equalising that that health disadvantage that some people have as a result of their mental health difficulties. This project is right in there trying to address that inequality.
Very good. And Anna, getting back to your work with the participants, talk a little bit about the kind of benefits you see them having. What are they saying? I mean, is it working for them?
Yeah, so like, I mean, sometimes some of the clients, like they tell me at the end, like, oh, like I really wasn't going to come today, but I'm so happy that I've done it. There's a girl at the moment who comes to her, who does the online exercise sessions with me after school and just before her after school study, and she said that her alertness is so much better when she does the classes with myself. Like there was one gentleman where he found it was easier to put on his socks. Then there's a gentleman then in psychiatry for later life, so he would have been in the residential unit. At the start of the 8 weeks, he would have been very refined to his wheelchair. So the focus of his program was increasing leg strength, increasing his balance. And then by the end of the 8 weeks, he was able to walk a short distance by himself, walk a short distance with the assistance of one staff. And where it used to take 2 staff members to transfer him from his wheelchair to a chair, it only took 1. So you can already see there where it's decreasing like the stress or the burden as well on staff members. So there's been a wide
and Paula, maybe to conclude, in terms of the sustaining and maybe the mainstreaming of this program, it sounds like you're getting great results. What would you hope to see? Where would you hope to see it going, Paula?
I suppose it's been a fantastic opportunity, and I suppose with what the Sláintecare Integration Fund has done is it's facilitated, I suppose, the mental health services to embrace physical activity by integrating it. It's given the sports partnership an experience of, you know, actually, you know, there's so much that can be done for individuals with mental health through providing this support, and it's given them experience of working, you know, to provide recovery orientated interventions into the mental health services. And then from the WIT perspective, it's also looking at them as an institution. They provide a lot of our health and exercise graduates, and they also provide a lot of our nursing graduates within the Southeast. So they're increasing their knowledge base as well. So I think every partner involved is increasing their capacity to look at physical activity in terms of mental health, and I suppose bring that whole idea of, you know, the brain and body where it's all the one. And I think that's the way the thinking is going into the future. And I suppose we've been very, very lucky that the Wexford Sports Partnership has decided to dedicate a Sport Ireland funded community development role to the ongoing work of the IEP project. Now, it will need additional funding. We would need additional funding to make sure that we continue the integrated practitioner model. And as we say, the pathways have been created through this project. So we just need a little bit more and we will have a fully functioning programme that will be both in-service facing, but also public facing as well, which is very exciting and very in line with the current policies around, I suppose, healthy Ireland, and also sharing the vision from a mental health perspective.
Very
so
good.
We're very excited, and we're very grateful to the Wexford County Council and the Local Sport Partnership, Fran, for, I suppose, her forward thinking in this regard, because I do think it's something that every county should have, you know.
Very good. Thank you, Paula and Anna. Sounds like you're doing great work down there, and best of luck with this. I think it has a bright future. Thank you both very much for your time this afternoon. So thanks to Paula and Anna there in Wexford, showing clearly how they're delivering the Sláintecare mantra of right care, right place, right time, with their integrated model, with a focus on mental health, building resilience, and all of it resting on collaboration. Thank you to them both. The second project this afternoon is from Dublin, Stroke Link, in innovating stroke support. An initiative that is seeking to provide holistic support systems for stroke patients as they transition from hospital care to support and care at home in the community. I met with some of the team earlier this week to hear what they're doing and how their project is getting on. So good afternoon, and I'm really delighted to be at the hospital. Dr. Michael Murnane is the consultant neurologist at the Mater Hospital, and I'm also joined by his colleague, Lauren McDunphy, who is the clinical nurse specialists. So these people are part of a team delivering a project called Stroke Link, providing improved patient experience and holistic support systems in the community. So our webinar today is all about partnerships and delivering innovative change using partnerships. And we'll talk about that with you and the challenges around that. But perhaps if I could come to you, first of all, Dr. Murnane, the project is about innovative stroke support in Dublin City and North Dublin County. Tell me a little bit about how you came to developing this project. What was the background? What was the problem? And how did the project come about?
So, we all know that stroke is very common, and 1 in 5 of us, unfortunately, are likely to suffer a stroke in our lifetime. And so it's a common problem, and we have a very good stroke service here in the Mater with multidisciplinary team input. And we're very lucky that the treatments for stroke, the acute treatments, have really changed over the last 10 years. And we have these highly effective treatments such as clot busting medications and thrombectomy procedures for taking out clots. And patients have recognized that, and when we see our feedback in our own patient experience surveys, and when we see feedback from the National Patient Experience Survey, patients are often very complimentary of the care they get in hospital. Where the challenges are, I think, is at that moment of discharge, when people feel less supported and really feel like things, can fall between the cracks, and they're not really sure where to turn if they have problems. And we have a very good service and a very good team in the Mater, but we found the same issues with our stroke service when we did ask people those questions. And I suppose that's where the germ of the idea of Stroke Link came from, trying to smooth that transition and have a safety net for people so that they felt supported. And secondly, to also empower them so that the team is not just the stroke team, the team is the patient and the carer. And I think doing that is a challenge, not just in stroke, but in all chronic diseases, trying to change behavior and change habits. So that's really where the germ of Stroke Link came from. The second part of the germ of it is we have an excellent collaboration with the National College of Art and Design. So I never met a designer until about a year ago, and we've been very lucky to work with them on several projects in the Mater. And we thought that they would be an excellent fit for this type of challenge, where we're looking to engage people in a way that they change their lifestyle, change their habits, and design thinking is I think the key to that, to really empathize with people, to see their challenges. So that's where the idea came from in the first place.
And that role of the design team, because that's quite unusual, in all the projects we're looking at, there aren't many of them that have pulled in a design team. Is that around designing some of the products, I saw sheets helping people to see what they're doing, to fill in how they're feeling, reminding them to take their meds. Is it that kind of design support that you've had?
Yeah, I think the first thing they say when you're a designer, if you're an Apple or you're an Intel and you're designing, the first thing is that you empathize. And I think that's, we try to do that as medical healthcare professionals, but when we come to quality improvement, we tend to measure first, whereas if you try and empathize and understand what your customer or your patient is feeling. And I think that's been the power of this, that we've really seen it through their eyes and really looked at their needs and tried to give them then tools that they need to be empowered and to be educated and to take control of their own care. And similarly, our colleagues in the community who also are dealing with these stroke patients and maybe don't see very many stroke patients, maybe a typical GP might see 1 or 2 a year, that they are up to date with how best to deal with these patients, how best to empower them. So I think there's 2 parts to it, two parts in terms of.
Very good. And maybe I might go to Lauren. Lauren, you're the clinical nurse specialist. Tell me about what the Stroke Link service looks like from the patient's perspective. What do they get? When do they get it? And what's your role in delivering it?
So the main thing that we find out from patient experience surveys is that once patients go home from the hospital after having a stroke back into the community, they feel overwhelmed, they're lost, they don't know who to contact or where to contact. They feel as though they have no information, they don't really know where to turn to. So that was our role of Stroke Link nurses, is to try and tackle that challenge. So with the assistance of NCAG, we developed this tool for patients, and we actually developed it in collaboration with patients themselves, their families, other community services, and also members of the MDT here in the hospital. We've also actually gotten some assistance from MDT in the community as well. So each patient is seen by either myself or my colleague Melissa Gannon as an inpatient first. So we like to see them on their ward, introduce ourselves, introduce the role of Stroke Link, give them a good idea in a sense of what's to come for the next 3 months until they're seen in the DNI. We provide them with the toolkit, booklet that we have designed. We go through each stage of their discharge. We give them a good in-depth description of the results of their scans, really go through in extensive detail what they went through during their journey as an inpatient and what's to come. So our role is strongly to encourage patients to take control of their own health once they go home. We try to empower the patients and make them become champions of their own health and their own well-being back home. And by doing this, we provide secondary prevention education, giving information on medications, and providing as much information as we can to ensure good medication compliance, which was a huge issue previously before Stroke Link, purely just down to lack of information that patients had and they didn't have anywhere to turn to. We also strongly encourage patients to monitor their blood pressure at home, which is one of the main secondary prevention interventions that they can do. And it's been great so far. We've had 100% of, on our first cohort of patients, we've had 100% of the patients self-monitoring their blood pressure at home, which is a great achievement that we've.
And when people go home, can you still link? Do they link back in with you? Is there some linkage?
Absolutely. So what we provide is we provide regular follow-up phone calls with patients.
Very good.
And their families and other community services. We also encourage patients to contact us as much as they need to and their family members. So we do a 48-hour phone call follow-up, and then we do a 10-day home visit, which patients have found invaluable as we're assessing the patients and helping the patients in their own environment as opposed to the bedside in the hospital, and patients have greatly benefited from that. So
great. And Dr. Murnane, maybe to go back to yourselves, I mean, I can see from the patient's point of view, the relief must be enormous, but also then starting to self-manage must be quite empowering. Well, what are the clinical benefits for the patients, but also maybe for the hospital?
So I think just building on what Lauren was talking to there, I think the power is in the tools that they really do engage people. So while they're in the hospital, we teach the patients and the carers to use things like QR codes, so they get videos, educational videos. The actual material itself is very beautiful and quite engaging and looks really nice, and that's the power of having a designer involved. And what we found is, we wanted to engage people, and we wanted people to, because around the world in chronic disease management, it's very difficult to get people to change habits of a lifetime. And I think that's been the challenge. But what we found is the engagement in self-care, like Lauren said, has improved. People are monitoring their own blood pressure at home 100%, as she said, whereas before that would have been down 10, 20%, so full 80% more. People are going in, their blood's checked, their cholesterol checked. their diet is better, their habits are better. We're starting to analyze that data, but the impact on the hospital has been really profound. So 1 in 25 of our patients before StrokeLink were being readmitted with a preventable presentation to the emergency department. And when you look at what happened to those patients, some of them would have had strokes, some of them would have needed long-term rehabilitation. The cost of that was approximately 970,000 per year of preventable readmissions. And what we found is that none of our StrokeLink patients, now of course it's not going to be like that forever.
Of course.
Analysed, none of our StrokeLink patients have been readmitted with a preventable. Some of them have been readmitted, but not with preventable strokes. We've also found the patient experience has improved. So 95% of people are now rating their care as excellent, their discharge care as excellent, which previously it was 44%. And 85% are saying they have enough information, whereas before it was 36%. So people, you'll hear in the testimonials, but people really like the service. And I should just mention that we were shortlisted for a Health Service Excellence Award based on this project. So hopefully the payers are listening too.
Yes, I did hear about that. Congratulations on the shortlisting, and fingers crossed on the winning of an award. One other area that I also read about and I wanted to ask you about is crisis visits to GPs and the impact that your service is having on that. Would you talk a little bit about what is a crisis visit that a stroke patient might have to a GP, and how your service is really having a good impact on those?
Yeah, so I think we've really been put into the fire with COVID. So normally when you're building something like this, there would be a huge amount of engagement with our GP colleagues and with our community colleagues, and all of them have been very, very stretched. So COVID has been the real test of whether this is going to work in the real world. And I guess it's been a challenge in that some of our staff are redeployed but also an opportunity in that we had to find ways to empower our GPs without taking up their time, and also to try and prevent those crisis presentations which are not time efficient for them and are worrying for them, and maybe to streamline people into more chronic disease management programs. So there's a new chronic disease management service in GP practices. The rollout has been a little bit slower, but our patients are starting to move into those chronic disease management clinics in the GP world, and we're trying to keep them away from those acute emergency presentations. So we're still working on the data on that, but we're very hopeful that it's made a significant impact in that regard.
Very good. And finally, last word to you, Dr. Murnane. Is this something that's transferable? Could you see it being up and running in other services around the country? And if so, what would you need to see that happen? We had that in mind when we started this. We thought if we're going to put all this work in and we're going to have a designer, we really want to make something that's not just going to be for the matter. And we've had preliminary discussions with our colleagues in the stroke program, the HSE stroke program, who are excited about this to build it into the early supported discharge services for stroke. And with that in mind, we really wanted to sort of focus on the human side. So to build tools that people feel supported and trusted, exactly as Lauren said. And we wanted to make sure, so when you're in hospital, everything is happening. I don't know if you've ever been in hospital, but Thankfully,
I have.
No.
I know, when you're in there, there's so much happening. So many people are coming in. You don't know who half of them are. They're all in scrubs or in PPE. So it's very hard to take in any information. And that's what we're finding with StrokeLink. So we're trying to give people bite-sized information at the moment that they can digest it. Try to empower their care so they have a care partner who's a second. And all that is built into the tools and into the program and the follow-up. And everything is fun and engaging. The QR codes are kind of a gimmick, but they're also cool to have the videos on the phone, and patients are kind of get a little shock when they have that. Everything is going to be put online, and we were also successful with the Public Service Innovation Awards. So we were given 50,000 to further build this program, to incorporate reminder text messages, and also to develop a website so that all the tools that we use at the Matter are available to people across the country, and they can edit them themselves. And I think it's scalable for stroke patients, but it's really the idea is this human empowerment, the engagement piece is for any chronic disease. So I think this potentially could be a very useful tool, or the building blocks of tools for many chronic diseases. So very, very excited, as you can probably hear in my voice.
Very good. Well, I'm very excited to hear about it. I think it's a superb initiative, and well done to you and all the team in getting it to this point. And I look forward to seeing it being mainstreamed and transferred across the country to benefit all of the patients. So thank you very much for your time this afternoon, and best of luck with the work. Thank you.
Thanks for the opportunity. Thank you.
I found it very, very good, especially the follow-up care, which I hadn't experienced before, because I'd had a minor stroke in 2016 and there was no follow-up care then. And having this afterwards now, I found it very, very helpful, very fruitful and very reassuring. You don't realise it takes so much out of you because it was a minor stroke. I only lost the use of my leg for an hour or two, but I really didn't realise how much my confidence was rattled until I started to go out in the fresh air again. Not only that, but the information they would give you, and you know, I'm a nurse myself, so of course I had loads of questions to ask, and they were very patient and very instructive. So that was a big help. And they would talk about my diet, my rest, and my well-being. You know, it was kind of very holistic, their care.
So a strong testimony there from stroke survivor Patricia, and thank you to Dr. Murnane and to Laura McDunphy of the Stroke Link team for developing this care pathway, and I think for the possibilities it displays for replication by those working with other chronic disease sufferers. As I say, great work. The third project this afternoon is from Cork, where the Cork Sports Partnership and Cork Kerry Community Healthcare, Health and Wellbeing have devised an impressive intervention. Let's hear now from our colleagues in Cork. To be joined by another project this afternoon, Welcome Active Well Communities Connect project, empowering communities to maintain their health through physical activity. I want to welcome Owen Carr to the webinar this afternoon. Owen, you're very welcome. And Owen is the project lead with the Cork Sports Partnership. Owen, as you know, a key plank of the delivery of Healthy Ireland and Sláintecare objectives is to keep people healthy and well, and your project, I think, is about that. Tell us how you're addressing that issue with your project.
Sure, and hi Grania, lovely to speak to you today, and thanks for giving me this opportunity. So yeah, Welcome Active is a new health and wellbeing initiative that's running in Cork. It's a joint collaboration between the Cork Sports Partnership and Cork Kerry Community Healthcare. And essentially it's all about shifting care into the community and empowering adults to manage their own health and well-being. And I suppose through the initiative, we're providing healthy eating and active living programs that help people to manage illness, avoid injury, and hopefully limit the need for hospital admissions as well. So I suppose the main focus is really on injury and illness prevention.
And tell me, how do you access the participants that you have on the programme?
So at the moment, we're taking referrals from the likes of GPs, hospitals, and other community health professionals. But we're also opening the programme up to the general adult population across Cork as well, and we're taking in self-referrals. And
when you say you're taking them in, where do they come for this support and service?
So the programs are delivered locally. They're aligned to each of the community health networks across Cork. And at the moment, all the programs are running online. So, you know, we advertise the program through the health services and then through our own platform within the Cork Sports Partnership.
Very good. And I know there are 4 elements to the project that you're doing. Would you just talk us through what the 4 are?
Yeah, so the 4 main programs would be Project Weight Loss, which is a physical activity intervention program. We also have an older adult program, which is called Staying Fit for the Future. It's designed around general balance and strength. We also have a nutrition and cookery program called Healthy Food Made Easy. And then the last one is the Made to Move program, which is a one-on-one physical activity program involving a Move mentor and a Move mentee.
And was it always your intention to do these online, or is that something you had to do because of COVID?
The intention really was to do them all in a face-to-face capacity, and I suppose that quickly changed when COVID hit. So we kind of had to go back to the drawing board with a lot of it in terms of the delivery, and we really had to adapt the program so that they'd be suitable to run online. So that meant, you know, changing the content, changing the resources, and then retraining and upskilling the community tutors to deliver them in an online capacity as well.
Right. And I, from the way you're talking about these, you're working in collaboration with a lot of people to get this project up and running. Would you talk, we're talking a lot in the webinar today, it's all about collaborations for change and innovation. You really seem to be doing this in action. Talk a little bit about some of the challenges of collaborative work like this.
Yeah, so I suppose, like you mentioned, we are working with a lot of different partners and stakeholders on the project. You know, for the programs, I suppose we're linking in with the likes of the community physios, the dietitians, the health promotion and improvement team. And I suppose some of the main challenges that we've had is really around that adaptation piece, you know, adapting the programs so that they're suitable for people online, and just so that they're as effective as they would be face-to-face as well. And I suppose the other collaborations that we might have would be in terms of the community link referral workers, and some of the social prescribers as well. So we're thankfully, you know, filtering patients and people that they would normally meet in the community right into our services and into our programs, which is brilliant.
Right. And in terms of one of the programs you mentioned is specifically around like older people. Did you find a problem there with, you know, using technology, or were they up for it? Did you get as many people coming forward from older age groups for engagement?
Yeah, that's a funny one. We really thought at the start that we'd really struggle to get that older population online and get them trialing the program online. But what we found is that there was a real demand from older adults to do just that. And where we thought they might struggle with the technology side of things, they really didn't after a while. You know, we did support them through the Welcome Active support line, telephone support line. And also our community tutors really supported them in getting online to start with.
Yeah.
But once they had done the program, you know, and logged in once or twice, they had no issues and they didn't look back really.
That's great. So will you be keeping the online element of it when we all go back to some kind of normality in the months to come?
Yeah, I think the key for us would be trying to get back to face-to-face eventually. I think the programs are just much more effective there. You know, there's that social piece as well. But I still see the advantage in having some online offering, especially for some of those hard to reach areas in Cork, where usually, you know, some of the program numbers might be quite low. I think in those instances, it'll be really useful to have an online offering. And as well as that, I think there's probably still a little bit of hesitancy around older adults in returning to indoor classes. So I think keeping an online offering for that purpose will be helpful as well.
Yeah, that makes sense. So looking back over the project and the work you've done, what would you say are the key outcomes or outputs that you have to date?
Yeah, so in terms of the outcomes, I suppose what we firstly wanted to do was improve health outcomes of the participants across all the programs. We wanted to demonstrate engagement, empowerment and self-care as well. So what we did is we quantified this through focus groups, questionnaires, health empowerment scales. And what we've learned from the research that we've done is that the programs were all effective in empowering people to manage their health and well-being, which is brilliant.
Super.
The second outcome as well was the development of a model to guide practice in healthy eating and active living. And we're currently working on that at the moment with our research assistant, Asha. She's doing some really good work there. And then the last outcome would have been the development of an electronic referral system from the health services. Unfortunately, with the pandemic, this last piece of the plan was delayed slightly. but we are hoping to pilot that very shortly in Cork as well.
Very good. So it sounds as if, you know, despite the COVID, you've pivoted, you changed your practices, you've gotten, you know, people onto the programs, and you've gotten the collaboration from the community. I know we are going to hear in a moment from some testimonies from some of your participants, and that's wonderful. But maybe to finish off, what have they been saying to you about what they're getting from the program? What kind of feedback are you getting on?
Yeah, so I suppose in total, the feedback's been really, really positive across all the programs, and that's even with the move to online delivery. So just taking the older adult program, you know, 100% of participants in that program noted that they were happy, really happy with the instructor, and that they'd recommend the program to a friend as well. All of the participants as well agreed that taking part had enhanced their quality of life, and even really, really simple things like there was one lady, she noted, you know, she had 2 very small grandchildren. She's now finding that she's able to engage with them much better after participating in the program, and it means, you know, getting down on the floor and getting up quickly is much, much easier. So I think it's all those little elements.
And they're so hugely important for quality of life, aren't they, Owen? You know, when you can't do them, you really feel that you're missing out on things. So look, it sounds like you have a great program going there. Cork are very lucky to have you, and best of luck with the rest of the delivery of it. Thank you very much for joining us this afternoon.
Thanks, Grania, and thanks to Sláintecare for the continued funding as well.
Hi, I'm Caroline. I'm living down in Cork, and I've just recently completed my second 12-week programme, and I've lost about 18 kilos or so, 17, 18 kilos in that time. I found it absolutely brilliant. The group dynamic worked really well. We moved on to Zoom fairly quickly, and just the accountability, the consistency of checking in twice a week for the online things, it made such a huge difference. I found that the keeping a food diary worked for me. For me, it was all about the food, healthier eating, things like that. The group dynamic and just worked really well. The leader, Kathy Good here down in Cork, has provided a huge amount of support and encouragement and just didn't let us away with anything. So WhatsApp, we have a really good supporter group that worked really well. I've since done the healthy food made easy 6-week course down here as well. It's just been very positive, very like physically and mentally stuck at home for the last year, and this has been a great thing to get me out of my own head, working on keep getting a bit fitter, making new friends, keeping moving, watching what I'm eating, and it's basically helped me in every aspect of my life. So I would encourage people to go for it. Thank you.
So active communities are healthy communities, and Welcome Active is working to help people manage their health and well-being. Carol Ann there, loving the food diary and being held accountable by the group experience. Really superb results for her personally, but I think for the project overall, really good results. Moving to the northeast now, let's meet our 4th project of the afternoon, arthritis rehabilitation through management of exercise and diet, armed with escape pain. Arthritis, an inflammation of the joints that causes pain and immobility, is one of the biggest causes of disability in Ireland. Let's hear now from this project, a partnership between Our Lady's Hospital in Navan and Meath Primary Care and Health Innovation Hub. I'm delighted to have Dr. Brenda Monaghan and Keelan O'Connor, a physiotherapist and research assistant with the project, here this afternoon to tell us about the work they're doing. You're both very welcome this afternoon.
Thank you.
Thanks.
So I'll come to you first, if I could, Dr. Monaghan. Armed with escape pain, a package of care delivered for arthritis rehabilitation in a community setting. Your project, Armed with Escape Pain, has an intriguing title. Tell us about the programme. How did it begin and what is its intention?
Okay, thanks very much for the opportunity to chat to you today. It does indeed have an intriguing title and it might be a little bit clunky. The Escape Pain Programme originated with Professor Mike Hurley in London, and we've been running it in Our Lady's Hospital in Navan for about 5 years now. And it was a kind of a systematic way of offering education and exercise to the cohort of people that have arthritic knees. And at the time we brought it in, we had a lot of people with knee arthritis on our waiting list, and they tended to get dropped back all the time because it wasn't seen to be urgent, and the urgent cases were kind of leapfrogged ahead of them. So we were looking for a way of managing them that gave them probably what was seen to be the best standard of treatment at the time, and also that we would be able to run it kind of in a more organized kind of manner. And there wasn't anything really in Ireland at the time that had that type of approach, I suppose, to it. So I did some training in London with Professor Hurley, and then I started it in Navan with a small group. And it was an education and exercise program that was delivered over 6 weeks, and patients attended twice a week. And from the beginning, the patients really liked it because they were in a class with people with a similar problem, and they were able to exercise, and there was education and kind of supervision, I suppose, for them. And they felt as if somebody was taking, I suppose, their condition seriously, and it was in an organised kind of manner. And we had a lot of nice handouts, and, you know, because it was an organised program, it came with I suppose, kind of a package of care almost. So over the years then, the patients who across the world, I suppose, people with knee arthritis tend to be overweight, or a group of them tend to be overweight. And the group constantly said they'd love, they were trying to lose weight at the same time. And the general education that you would give them would be that would be beneficial for their knee, because their inflammation would reduce and their general level of pain would reduce. So after, when a lot of patients tell you the same thing, you kind of realize that that's what the problem is. So I was looking for a program that also offered a weight management part to it, and there wasn't really anything. So then when the Sláintecare advertisement came up, I put together a kind of a project to try and address
Right, so that was the innovative element of it for you.
Long-winded version, yes.
No, that's really interesting. And what kind of results did that addition to the program give you? So the idea of, yes, I need to lose weight to help my knee. What did you do to help them get over that big hurdle?
We were looking for a dietitian really to advise us on that, because it's not a physiotherapy area of expertise, and it was very difficult to get. Dietitians are very scarce in Ireland, and there was none in the orthopedic service, none in Meath. In our hospital, there was just one for diabetics. So I kind of made contact then with the Health Innovation Group in UCC, and they kind of helped me, I suppose, to approach a couple of dietitians based really in the universities, one in Dublin, and then we got in touch with Ruth Reedy through the IMDI, and we were just using her as a kind of an information or an educated source as to what we needed, and we didn't have any funding or any money. So it was really only when the funding came through the Sláintecare that we were able to approach her and get her to design the dietetic part of the program.
Very good. So maybe go to your colleague Keelan. So Keelan, you're working with the patients. Tell me a little bit for the arthritic sufferers, what does the rehab program entail for them, and how do you actually access the patients?
So initially we began the program, we set it up for face-to-face, so they would have been referred into the physiotherapy department. I would have been put on our waiting list, and we would have brought them in individually for an initial assessment. So we would go through our routine physio assessment. We also looked at their goal setting, what they wanted to achieve, and we took some standardized outcome measures that we would take before they begin the program, and then we take them again after they've done the program. So once we've done our assessments, we would, if they were appropriate, refer them for the escape pain program, and then they would be put on the list for the next available class. So the wait time for when they would be entered into the class was significantly reduced. And then, so initially in the first class, we would do an introduction of ourselves as physiotherapists and the team, and we would set out the 6 weeks how it would run, and we would begin with some basic exercises, introduce them to the patients, and then as the weeks go on, we would progress them. We worked on lower limb strengthening and overall body exercises that could help to target their knee.
Very good. And you mentioned there the original plan was face-to-face. Did you have to pivot for COVID? Did you have to change?
Yeah, so unfortunately, due to COVID, we had to stop the classes. So initially, we didn't really know what the plan would be, how long it would take before we would be able to resume the face-to-face. So then the service was adapted. So we started running it virtually. So what we did is we contacted all the patients and asked them if they were willing and able to do it virtually. And I have to say, a lot of the patients initially weren't familiar with technology or internet, but they really did take it into their own hands to go about to learn how to use technology.
Very good.
So we would have assessed them initially. We started using telehealth, so they would be given, again, an individual physiotherapy assessment. And we would go through all the same things that we would as if we were face-to-face, and we took our outcome measures and went through suitability for the programme, and then we referred them to the next virtual programme.
Very good. And Dr. Murnane, can I ask you, our theme this webinar is looking at collaboration and partnership and the importance of delivering. And I'm just wondering, working in the primary care in the community and, the hospitals, universities, you seem to have a lot of partners.
Collaboration,
and collaboration. Just maybe talk a little bit about the challenges of that and how you got over that, and just, how do you bring together people from maybe different disciplines, different teams, to focus as you have done on one particular group of patients?
Yeah, I think that there is certainly a challenge in that. And I suppose when we began, our patients initially just came from the hospital sector, and the ones we had on our waiting list had already transitioned into secondary care, and they'd seen the consultant. But we realized, whilst we knew that was the best way to treat them, we didn't have access to them at primary care. So in order to start the program at all, we had to bring in the physiotherapists that work in primary care. So Pauline and Maria, two physios that deliver the program as well, they were based in primary care. So we had to meet their manager and see could they be released in order to give the classes. And the other thing about that is that, like most services across the country, there was a primary care waiting list and a secondary care waiting list, and generally those waiting lists aren't mixed. But because we had the agreement of both physio managers, we were able to treat the waiting list for people with knee problems as one and then refer in, and obviously that works much better.
Very good. And the benefits for patients, they're getting seen, they're getting treatment, but there are benefits for the hospital as well, aren't there? I mean, working in a community setting, people are getting treated maybe closer to home. Did you find that there were benefits there?
Yeah, well, there are benefits for patients. And I think, looking at the evidence that's published to date, it is much better to treat people much earlier in the course of their disease. So we would hope to push it back further so that as soon as you see your GP and he thinks you have a problem with your knee, that you begin that program of,
early intervention.
Early intervention.
Yeah, makes sense.
Yeah.
So talk a little bit, I'm just wondering about the key outcomes. What are the key outcomes from the program that you've seen? And maybe what are your patients saying about the program?
Yeah, well, I suppose because of COVID, because we had to redesign the program hugely after Christmas, because our first program was disrupted, we did outcome measures at that stage, kind of more to redesign the virtual program we were going to go with. So our outcomes aren't complete yet, is really what I'm trying to say, and our program won't finish really until June. So with the people who we've had through the program to date, the two outcomes we've looked at are reduction in pain and reduction in weight. But not all of them have seen the dietitian, so it's a little bit vague as yet. But our group so far have had a huge reduction in pain. I think what we had estimated was about 8%, and they were about 64% better from how they significantly better. The weight reduction is a little bit less. We had predicted that they would lose 5% over a year, and we have about 1.4% over 8 weeks, 12 weeks. So we're speculating that if we look at them in a year, they will have lost 5%, but we're not at that point yet. So I couldn't hand on heart say that's how it is. And then also because of we had a few people who wished to kind of go to use the virtual program in the beginning, so they weren't all actually very overweight. So it sort of skewed our results a little bit. But we did find that there was a dietetic deficit even in those, that they were missing significant minerals, calcium and that kind of thing. So they benefited also from the dietetic input.
Very good. And Keelan, back to you then. So we've heard the outcomes. What are the patients saying about the program? How is it impacting on them? What are they saying? Is it working for them?
Yeah, so when we first meet the patients, we'll get them to tell us what they like to achieve, and we try and help and facilitate them to achieve what is important to them. So for instance, we have patients that, particularly stairs is one thing, but if you think about socially how that affects them, so going to relatives, they won't go to their house because the toilet is upstairs and they're afraid that, or they'll say playing with their grandchildren, being able to get down onto the ground, they won't be able to get back up, particularly people that if they find that they won't go out for a walk with their friends because they'll start to develop pain in their knee or they won't be able to keep up. And that's all the feedback they're telling us now, that even early on into the program, they're noticing little changes that they're able to improve on. And, once they achieve one thing, they're telling you what's next on their list.
Very good.
And we do have a lot of people that, are still working. So the fact that they're able to fit the virtual service in to their job, and they've actually found that, while they're at work, they have found significant improvements.
Very good. So, it sounds like you're hitting all the right notes. As you say, it's with the COVID disruption, maybe you've had to move your measurements somewhat, but I want to thank you both for joining us this afternoon. Wish you the best of luck with the programme and your continued delivery of it. Thank you very much for joining us.
Thanks very much. Thanks.
So great to hear there from Dr. Monaghan and Keelan O'Connor in the Northeast, providing real relief for those suffering what can be really crippling and debilitating knee pain. Thanks to both of them for joining us. So, you have heard about the work of these 4 collaborative projects, all funded by the Sláintecare Integration Funds. And I have a panel now from the projects you've just heard from with me, and we are taking questions, so do send them in. I'm delighted to welcome back people you've met earlier in the afternoon, Anna Flynn, Dr. Michael Murnane, Owen Carr, and Dr. Brenda Monaghan. Maybe just to go back to you, Anna, we had a really lovely comment in from a community pharmacist who says, I just want to say how brilliant this programme sounds. And she's asking you, is there a role that she as a community pharmacist could play? For example, could she refer people into your programme or find out how to do that? What's your response, Anna, to her? You just unmute there, Anna, if you unmute yourself. Thank you.
Lovely, sorry. Firstly, thank you very much for your question. Unfortunately, because this is a pilot programme, it's only based in South County Wexford. So I'm currently the only exercise practitioner doing this at the moment, and I can only take referrals from CAMHS in Wexford, Psychiatry of Later Life, Recovery, Rehab, Maryville and Summerhill. We do have plans, however, to develop this role and expand it a little bit more within County Wexford still. So we have future plans now to have an exercise practitioner to cover the north, to cover the south, and one person then to cover CAMHS in south and north Wexford. So we have plans of making it bigger, but at the moment that's just where we're refined to at the moment.
Very good. So perhaps down the line, as the project gets more mainstreamed, because certainly we're hearing from a lot of people, their community pharmacist is often their lifeline into, advice if they're not maybe signed up to a particular program. So she's very excited to be involved in the future, and I'm sure there are others out there the same. Just maybe while we have you, Anna, just to ask you, just talk a little bit about how COVID-19 impacted on the delivery of the project.
Yeah, so originally what we wanted to do was do one-to-one training classes, be out in person, doing group classes with the guys in the mental health services, promote all the community physical activity initiatives that would be going on, support the community integration, and of course, have myself personally integrated on all the multidisciplinary teams. However, when we did start doing the exercise programme, the first block took place just after the first lockdown. So where possible, the classes had to be conducted outdoors, and of course anything that was done indoors would have to follow the strict government protocols regarding the distance or the social distancing and wearing the PPE gear. So then in block 2, which would have been carried out around September, October, almost all of my classes then were conducted outdoors. So I would have been using like the local outdoor facilities in the parks and doing all the classes as much as I could out there. And then block 3 and 4, we have level 5 plus. So that's where the real adaptation came into place. So there was no longer any personal face-to-face exercise classes. Everything was done through telehealth. So the personal training classes would have been taking place over, let's say, like Zoom or like the video calls that way. And then I would have recorded exercise classes, would have sent them on to clients, would have sent them out personal plans in the post. So there was quite a variation, but we still managed to deliver the program and
very good. And Anna, finally, would it be your intention to go back to the parks and the back gardens and the outdoor? I mean, is that what you would hope to do?
Yeah, absolutely. I know, I think particularly with mental health, like developing that rapport is like very, very important, and sometimes we miss that with the virtual. But in saying that, virtual also really opened my eyes where it actually was very suitable for some people, and it was just convenient, let's say, for teenage girls. So there's a time and a place, I think, for either the virtual and the face-to-face.
Very good, great, and you're well set up to do either. Thank you. So maybe if I could come back to our colleague from StrokeLink, Dr. Murnane, thank you for joining us again for the panel. I know you've developed some really useful partnerships and collaborations in the devising and the delivery of StrokeLink. Would you like to tell us a little bit more about them? You mentioned the designers, but I know you've wider partners involved, so maybe just talk a little bit about those and the collaboration.
Thank you so much, and thanks for a great session. So yeah, it's really been a learning experience for me, and very, very helpful to have this opportunity to engage with our community colleagues. We in the hospital, we like sending people letters, but we often don't meet them face to face, and this project has really brought us together with our colleagues. Not so much face to face with COVID going on, it's been more on Zoom, etc. But we've had the opportunity to meet colleagues in GP. We've met the lead, David Gibney of CHO9 Community Health Network. We've met the Dr. O'Shea, the lead for digital health in the ICGP, public health nurse leads in CHO9, and the community health team there. And the Irish Heart Foundation at the start of the project were extremely helpful in giving us access to patient support groups, which were the germ of this, and a lot of the very good ideas came from that. And then throughout the process, our designer and our team have been working with patients and working with the community team to fine tune the tool itself, because it's fine having a tool that looks very nice, but if no one wants to use it, it's not going to be very effective. And that's really been the triumph of this, that we've designed something that hopefully people will use and find enjoyable, and engage with, and find fun. So we've got a lot of really good feedback, not just for the tool, but the tools that we use, the digital tools that we use, but also in terms of how the service works, and making sure we're giving people the right bit of support that they need at that right moment. So maybe they're in the hospital, there's a lot going on, like I said in the video, they can't take much in, but maybe 2 days later they're at home, things are a bit calmer, and they're very open. And I think that's been the feedback that the patients have given us, and the community teams have given us, that we can get there with the right information at the right time in the right way.
Yeah, very good. Thanks, Dr. Murnane. Just maybe go to Dr. Brenda Monaghan for a moment. A theme in some of the projects over the last while has been the challenge around recruitment, or cross-agency boundaries, or divisions even within the HSE. And Elaine has texted in to say, what would people like to see happen to make this less of an obstacle? You know, delays you had in trying to find dietitians, or other people trying to bring in advanced nurse practitioners from other parts of the sector. Is there something from your experience that you think might help to streamline that?
Well, I think actually the Sláintecare projects as they stand have effectively done that, because previously we wouldn't have worked directly with our primary care colleagues, or you know, in a project like this. And I think that has allowed us to kind of work across, like we worked with the whole County Meath knee arthritic waiting list, as opposed to just looking at those that were already referred in through secondary care. And I do think
that collaborative nature of work is really, what gives patients the best service. So I think if you bring like-minded people together that have an interest in specific areas, they'll definitely work. Health professionals generally don't see those specific boundaries. They'll work collaboratively quite well, and we didn't really, once we got it off the ground, we didn't have any issues really with that.
Yeah,
and I think also it's good to work with people from, the dietitians and nurses, and it's very good if your team is broader. And I think our project particularly would benefit from psychology services as well. And I think the key probably is to go back to the patients and see what they think the service, best needs. And often if you ask them, they'll know which parts are missing and what would allow them to stay away from surgery and manage their own care. I think that's what works
very
best.
good. And I see you nodding your head there, Dr. Murnane. Would you agree with that, with Brenda's take on this, that the project work has actually helped break down some of these, maybe barriers between various elements of the health service, and you end up just pulling in the people you need to pull in and getting it done?
Yeah, one of the big jobs of the more junior doctors is to do discharge summaries, and it's usually a big piece of work done under pressure, just the patient's going home. But when we meet our GP colleagues who those discharge summaries are directed towards, we realise that what's in there is not what they want and what they need. And even that simple thing, it's that ability to get that feedback very quickly changes what we're doing. So we're giving people the information they need that they can action in a way that they can. So not just our patients, but also our community healthcare colleagues. And I think what we're trying to do with StrokeLink is to maybe make that more structured, in that we're hoping that all the tools that we're developing will be put on a website available both to patients, carers, and also to healthcare workers. So I think that's been the learning for me, and certainly part of the enjoyment of the project, getting to know colleagues in the community.
Yeah, exactly. And out of your own silo, perhaps, as the phrase goes. I see a message coming in there. Ursula from Healthy Ireland says she's very excited listening to all of the projects. And the good news is that there will be more dietitians around the country within the next 6 months. So obviously there are plans afoot around that. And anyone who is looking to have attention paid to diets and the advice, are so important to get proper advice on this. It's great to hear there are more coming through the system. I'm going to go to Owen now, if I might. Owen, would you just talk a little bit about what you see as the next steps for the Cork Sports Partnership project? What do you need to make it sustainable?
Sure, Grania. So I suppose for us, I think the next steps really is to expand the programs more into some of the other health networks across Cork. We're already hitting a good number of those at the moment, but I think having the full suite of Welcome Active programs across those 11 health networks would really be the end goal. And then I suppose just in terms of making the project sustainable, I suppose the key thing would be program and project funding. But I think as well, developing that referral pathway from the health services into our programs would be really, really useful as well. It just means we'll get the right patients and getting those that kind of most need the help first.
Right. Okay. So that makes sense. There's a question come in here, and maybe it's for both Dr. Monaghan and Dr. Murnane. It's a question saying, Mary Jane says, brilliant webinar. Considering the success of the projects, have the participants been asked by colleagues if they too could use similar tools and techniques for their own patient cohorts? And I know, Dr. Murnane, you mentioned this, that you would hope that the model you're using could perhaps be used for other chronic patient care.
Yeah, I think humans are very different, and they have different needs at different times, but fundamentally we are humans. And I think the challenges that we face in one disease, we face in other diseases, and changing behaviours. I think a lot of the tools that we've been developing in StrokeLink are very applicable to other chronic diseases. That ability to educate people in an engaging way, I think is applicable to many chronic diseases in many contexts, and also that transition. I think when you look at national patient experience surveys, generally people, as I said in the video, rate care in the hospital very, very highly, but the transition of care is always a challenge, and not just in Ireland, across the world. So I think if we can crack that, I think some of these tools can be very helpful in smoothing that transition and supporting people.
Yeah. And would that be your view, Dr. Monaghan? Would you think that, some of the tools, when you were talking about how you found this program, a colleague in the UK, you learned about it, you brought it back, and this, a program to help people escape pain. I mean, there are key elements in it, but they are transferable, aren't they, perhaps to other,
very much so, yeah. And particularly in the immediate term, it would work with patients with arthritic hips or arthritic, low caused low back pain. So they would be the groups that we, would look to kind of roll it out to initially. But certainly, I think it's very good systematic approach, and the weight management component as well, definitely does tick a lot of boxes for people with chronic illness.
Yeah. And I mean, I was interested in your final comments there. I know you don't have all of your results, and the disruption has affected that. But, 64% of people reporting, improvement in pain.
Significant.
Like that's life changing in terms of the kind of things you could do. Where would you like to progress the project at the point you're at now? You're going to finish the preliminary research and looking at what has happened, what's needed. Where would you like to progress with it now?
Yeah, well, we'd like to see it kind of roll out to the primary care network system across the country, really, with additional physiotherapy, dietetic and admin support. It would be easy to replicate it across many areas, across the country. And the other thing then I would think it needs is continued research evaluation to see at what point in a person's condition you get the best results out of it, and how soon they might need refresher courses, maybe in a year's time or 2 years' time. So what we're trying to do really is stall the amount of time to surgery and sometimes postpone it altogether, in certain, if people get proper conservative management at an early enough stage, I think that's very possible.
Yeah. And, I love this idea of, all of our best medical people, they find things and they see things and they think, I could bring that back. I mean, I'm sure Dr. Murnane would attest to that. But what was it about it did you go to the UK to see this, or had you heard about it and decided you were going to follow?
Well, actually, what I did was I was evaluating the people on our waiting list for physio, and there was a huge cohort of them. We took us ages to get to, and when we got to them singly, we weren't really making any effect on it. So I kind of Googled initially to see what kind of programs were out there that you could deliver in class sizes, and that's kind of where
that's how you found it. Fascinating. And Dr. Murnane, for you, how did you find this? Is this something you thought up yourself, or did you see it elsewhere? Are we following best international practice?
I like to think we brought something innovative to the table, but of course we're building on the shoulders of others, and there are colleagues in other parts of the world, and particularly there was a colleague who was just starting lockdown in Australia and had a little bit of time on his hands, and he emailed me all his documentations for a support program that they had, and we've built on that, and we've done some different things. We've added some very nice tools, and the design element I think has added a whole new dimension to it, and adding fun things like QR codes that people can scan and learn how to do that in the hospital. I think that's kind of the fun element to it. But certainly, we learned from others and built on that, and we're very grateful for that.
Very good. Okay, look, we've put the questions to you. Your responses have been really interesting, but really the work that you presented in the videos that we did of the projects, each of you, I think, showing the importance of collaboration. It's not without its challenges, so we're not painting this so it's all really easy to get all these people together and to have the kinds of outcomes and outputs that you are having. But I want to thank each of you. To all of the guests here today, to Laura McGahey for sharing what we can expect in the Sláintecare strategy. Well done to all the great project work as it continues. Can I also add my thanks and appreciation to all of you affected by recent IT events. I want to thank you for endeavouring to continue to meet the needs of your patients and for continuing to deliver care despite those IT issues. I salute and admire you. Thank you all for the passion and commitment as you show up every day, despite some of those really unusual circumstances. COVID is one thing, IT hacks is another, but showing up and continuing to do the work is really appreciated, I think, by the community. Today's emphasis on collaboration and innovation, I think, is certainly a message of hope and really concretises what Sláintecare is delivering and shows how the many innovative ways of working are making our health and care services better for all. I want to thank all the team who helped produce the session today: Rosaline Harlan, Muriel Farrell, Lindsay Dre, Ingrid Doyle, Erica Kinsella, Suzanne Lynch, and Tom Dukes. You can watch this webinar back or recommend it to your colleagues. It will be available on the Sláintecare website, and do send us your feedback. The questions we didn't get to answer, although I think we did get through all of them, we will post answers to you. But from me, Gráinne Healy, and from everyone this afternoon, please continue to stay safe, continue to wash your hands and hold firm. Thanks, everybody.